Hello everyone, welcome back to our channel OT Nexus. Today our topic will be endotracheal tube. Hi everyone. So the endotracheal tube or intratracheal tube, or we can say a tracheal catheter, is a kind of device that we use to intubate the patient, and the procedure is called itself intubation. It has various parts. It is an ideal endotracheal tube which is cupped. There is a tube that is uncupped, and here is the cup of the ET tube, and this one is our machine end, this one is our patient end, and here there is a small hole that we use to known as Murphy eye. The main or major function of this Murphy eye is to, when the main hole is blocked near the patient end due to secretion, this Murphy eye can be used to provide ventilation. And this one is the another hole, that is the main hole. It is also known as bevel. And this one is our cup, and there is a marking in endotracheal tube, and there is written as internal diameter, like the diameter of the tube, internal diameter of the tube. And this one is our red rubber catheter. The major advantage of this red rubber catheter is that we can use it repeatedly, and it causes less trauma to the patient. It causes less trauma to the patient. So our next discussion will be how to determine tube size. For an average size of tube will be, for women is 7.5 millimeter, that is internal diameter, and the average size for adult male will be 8.5 millimeter. And for children, there is various formulas of determining the size of endotracheal tube. For the children who are below 6 years, the tube size is calculated by age by 3 plus 3.5, and for children that are older than 6 years, their tube size is calculated by their age by 4 plus 4.5. And for the children who are above 2 years, the internal diameter is calculated by age divided by 4 plus 4, that is also known as our modified Gold formula. And for children or neonate 3 months of age or younger, the tube size is calculated by 3 millimeter. And for those of 9 months of age, 3 to 9 months of age, the 3.5 millimeter internal diameter tube were used. And for children or neonate over 9 months of age, the internal diameter is calculated by age in years by plus 16 by 4. This is how the tube size are calculated. And now for cup tubes. What are the size will be for cup tubes? The internal diameter for cup tubes will be that h by 4 plus 3, and a tube of 0.5 to 1 millimeter smaller than that calculated for an uncupped tube. Next, come into the tracheal tube cups. Our tracheal tube cups are something that is inflatable, that is connected with an inflate balloon, that also known as pilot balloon, and the cup is known as pilot cup. We give some kind of 5 or 8 ml of air into the pilot balloon, and that inflate the cup. So there are various kind of cups in ET tube depending on the volume and pressure. So we can divide it in two types. One is in case of low volume high pressure cup, and another one is high volume and low pressure cup. Now we will understand these cups. As we have discussed earlier, that there is two type of cup. One is low volume high pressure cup and another one is high volume low pressure cup. First we will discuss what is low volume and high pressure cup. As the name already suggests that in this type of cup the volume will be low and the pressure will be high. And as in the picture given, this type of cup has very small adjacent area to the tracheal wall, and it occupy very less area than high volume low pressure cup. And this cup inflates in a circular shape and it's provide a good seal and it prevents aspiration. And I have already told that it has a smaller area of contact. And what are the advantages? First, before going to the advantages, we mainly use this kind of cup in red rubber tubes that are used in red rubber tubes, and it has relatively low compliance and thick rubber, and high volume low pressure cup has thin rubber, and we will discuss it in the next slide about the high volume and low pressure cup. First we have to know what are the advantage and the disadvantage that low volume and high pressure cup provide. So the advantages, it as I have already told you, that it protect against aspiration, that it as it contains low volume but the pressure is high, so there is very decreased chances of leaking fluid into the lungs, so it provide a protective barrier against aspiration, and it can also increase the visibility during intubation than the low pressure cuff or high volume cuffs, and it has lower incidence of sore throat, and it are less expensive. And the main disadvantage of this kind of cuff is, as the pressure is very much high, it crosses the mucosal pressure and is damage to mucosal membrane, and that leads to mucosal ischemia, development of tracheal scarring, tracheal stenosis. If we used it from prolonged times, it can cause ischemic damage to the wall of mucosa of trachea. So this is about the low volume and high pressure cuff. The main funda of it is that the volume will be low and the contract area to the tracheal wall will be low, but the pressure will be high. As the pressure will be high, so it will cause mucosal injury. Now we will understand high volume and low pressure cuff. As the name suggests, high volume means it has a larger area of contact with the tracheal wall rather than this low volume high pressure cuff, and it has a conforming shape and it will occupy a larger amount of space to tracheal wall. And this kind of cuff, like a high volume and low pressure cuff, that is made up of thin and elastic material like PVC, and it has thin wall. In low volume high pressure cuff, it has thick wall, and in case of high volume and low pressure cuff, it has thin wall. So the main difference between this kind of cuff is one has thick wall and another one has thin wall, and it seals the trachea without stretching the tracheal wall. And the advantage and disadvantage of the high volume low pressure cuff will be that the advantage will be that it is possible to measure and regulate the pressure as the pressure is low in this kind of cuff, and it is impossible to measure the intracup pressure that is closely approximate to the pressure of tracheal wall. And the disadvantage of this cup are that as it has a larger volume and it is contains more area, so it's difficult to insert it into the trachea, and it obstructs the view of larynx, and it can cause sore throat, and it can't properly prevent aspiration. As it has low pressure, fluid can leak from it and it can go through the lungs and cause aspiration. And it has also some folds that also called as microfolds, and that create some channel for passaging of some infectious agent, and that is the main reason to the patient developing for ventilator associated pneumonia. It provides a channel for an infection agent to go into the lungs and causing ventilator associated pneumonia. And especially in this type of cup, when we use nitrous oxide, as we know that nitrous oxide has a second gas effect, means it increases its own concentration as well as it increases other gases concentration. If we use nitrous oxide in this kind of cup, nitrous oxide, what it will cause is that it will doubles the volume of the air that is in the cup, and resulting to the injury to the tracheal mucosal layer. Next is foam cup or lens cup. Foam cup is a kind of cup that is made up of polyurethane foam and that comes with bigger diameter and residual volume. This cup is deflated. We can deflate it by using suction, and when the negative pressure is released in the cup expands, and when in place in the trachea, that the amount of foam that expands determines the pressure. If the foam is expand, the more the foam expand, this lower the pressure, and the tracheal tube has good seal at low tracheal wall pressure when used according to appropriate sizes. Next is lens cup. The lens cup comprises a latex pilot balloon inside a transparent plastic sheath, and it has a pressure regulating valve between the balloon and cup, and this kind of cuff is designed to maintain the intracup pressure of like 20 to 25 torr at the end expiration. The pressure regulating valve permit gas flows from the balloon to cup and vice versa. Means that it goes from balloon to cup or cup to balloon. This prevents gas leak around the cup during the positive pressure ventilation and nitrous oxide that related cup pressure rise, and it also eliminates the needs that we use to measure cup pressure by using a manometer. It omits this, that it really eliminates the need of measure cup pressure, and it can't provide good seal in patient those requiring high airway pressures. And if the balloon is compressed in these lens cups or overinflated, the intracup pressure will rise. Next is that what should be our cup pressure. A cup pressure will be that it will provide a good shield, but it will not compromise the blood supply of trachea. And the cup pressure recommended is in between 18 mmHg to 25 mmHg. And in cup leak test are measured by exerted the cup of the tracheal tube on tracheal mucosa. The valve on the breathing circuit is closed partially and the back is squeezed, that increases the pressure till audible leak is detected around the tube, and the airway pressure at which the audible leak is recorded, that is the pressure exerted by the tube in tracheal mucosa. And in children, lower pressure should be used to prevent tracheal ischemia, and intra-cup pressure and the volume of cup inflated with air rise when nitrous oxide is administered for long time. The rate of diffusion depends on permeability of cup materials, the surface area of the cup that is exposed to nitrous oxide, and the intercup pressure monitoring can be done manually either by palpation over the larynx or palpation with the pilot balloon, and it can be measured by connecting the inflation tube to a pressure transducer of a monitor or direct measurement with the manometer. What is said is that we can monitor the pressure by connecting the tube to the pressure transducer of the monitor, or we can directly measure it through manometer. And the ET tube has, and the machine, or we can call as its proximal end part, that is of 15 millimeter. Often this question asks in every competitive exam that the ideal connector size of endotracheal tube or machine ends is 15 millimeter, 22, 20. This how the question comes. So the ideal connector size of machine end or proximal end will be 15 millimeter. So this is some picture that is Magil oral connector, and these are catheter T-mount. It is mainly used in head and neck surgeries or in thyroidectomy surgeries where surgeon needs the operative place closer to mouth. In these kind of cases, we use this catheter T-mount. It also connected to ET tube to breathing circuit, and this is also a connector that called magic oral connector. And these are most openly used in head and neck surgeries. Thank you for watching. We will discuss about different kind of endotracheal tube that are used in different surgeries on our next video. And if you like this video, please hit a comment on comment section.